Okay, you're in charge of my voice, all right? Okay. We have to give him a responsibility. You can put it in my pocket or wherever it goes. No, this is perfect. I guess I'll be introduced first, but no, I look forward to this. What, darling? No, I'll go with the slides. Yeah.
Just double check.
Yeah. Oh, yeah, yours. Thank you, darling. I love you. Hold on. I can't. That's it. The shoulder, yeah.
Still wait a minute because somebody still have lunch. Yeah, so we wait for somebody. And then
Shoulder, they know which one to do.
Yes, it'll be the knee and then.
陈楼，那个外面还有人吗？可以进来喽。
OK，
可以进来喽，准备哦，要准备上课喽。
Do I click it or do you?
It's going to move when you say forward.
Okay.
Okay.
All right. Thank you.
Wait. Okay, we got a surprise for you.
We got a surprise special guest.
Yeah, it's our grandpa or my brother. So it's family union here. So this afternoon Stanley will be here together with us and be the moderator. So also share some the history of Hong Kong, Taiwan, and between AOM for us. Okay. So let's give time for Stanley.
Good afternoon. So immediately after your lunchtime, I think it's time for me to. I don't have to introduce the speaker. That's why I just like to share with you the history and the story and the road of my learning about prolotherapy and why you have to learn all the knowledge and the skills taught by our grandfather Lenny and beyond.
Yeah,
these are so important. In fact, I met Lenny in 2002 in Colorado Springs or in Denver in the snowy days. And then there's in a hotel. And at that time, apart from Lenny, was also Tom Raven and also Mark Cartieri. And at that time, I didn't know what I was learning. Completely didn't know. My brain was just completely empty, and I know nothing. So you guys are very, very lucky, and you guys are fortunate because you already have a lot of the background knowledge to start with. I think these are so blessed. And then also I met Dr. Beyond here back to 2005 in AOM. At that time, I met Lenny was AAMM. In fact, it's not AAOM. Okay, and that's how I started. Then it's at that time, I was stressed. Biomechanics, and you have to treat the whole person. Very important. You have to look at the patient. Even the low E and the high D from Dr. Lenny, I still remember that. I know nothing about that at that time. And then I just get the concept. I have to look at the whole person. Each time when the patient comes into your office, you have to look at the patient, how he or she walks inside your clinic, and then you decide. And then those are the experience and knowledge you're going to accumulate. And I still remember in Colorado Springs, I met Dr. Beyond here in a consultation room, and it's a conference room. And then it's already the AOM's annual meeting, and it's a group tutorial. And then Dr. Beyond at that time said to us about the holistic approach of prolotherapy. You have to inject, you have to inject the right target, not only inject one part. For example, a patient comes to see you with a knee OA. Don't only look at the knee. You have to look at the hip, the lower back, the foot, and you have to look at the whole person. And that's the reason why you need to learn comprehensively. Why you need to learn all these things from this grandfather of prolotherapy. It's so important. And then throughout the years, I accumulated many different skills, knowledge, ultrasound, but my thinking is still the same. You have to treat the root cause. Don't only treat the consequences. If the patient presented with low back pain, presented with neck pain, presented with shoulder pain, presented with supraspinatus tear, that's the consequences only. Root causes are something else. So you need to back to the very important thing is to take history. Dr. Beyond was stressing that at that time, taking the history, what really happened at the time the patient developed the problems. Very important. So it took me several years to understand all this. And even nowadays, I'm using ultrasound-guided injections. My thinking is still the same. Don't treat the consequences. You have to treat that to ease patient's pain, but at the same time, you have to treat the root causes. I think I won't take a long time from Dr. Beyond, but I really want you to know why we can fix patient's problem better. Just now, during lunchtime, we were discussing about how you can use the bullet, which you think is the dextrose, the PRP, the thing is the bump, and the so-called the bone marrow aspirate, which probably is the nuclear weapon. Okay, so whether you want to use that to hit your enemy, I think the best way is to use one bullet to kill the general. You use one bullet to kill the general, and in fact, the whole army just collapsed. So I think the best way is to find the root cause, treat the root cause, and then you will get results from that. No matter you're using dextrose or using PRP or so-called the other stronger solutions, but you have to hit the right target. So I'll give the time to.
Thank you. Thank you very much. Thank you, John. Before we start, I'd like to talk to you for a few minutes. I was delighted to listen to Lenny today. He had so much knowledge to give, and I was just delighted to see how he presented it. It is very hard to absorb it all. Thank goodness you have his notes. But this is the issue here. When you see a patient, the first thing when the patient comes into you, you are observing. You're observing gait. You're observing how they sit. You're observing how they move. And then they will come to you with a specific complaint. It may be mild. It may be severe. But then always get a good history, as good as you can, and do a good physical examination. And don't just focus solely on the problem, but you focus on the entire person. And you'll find in the future, because you're all family physicians, you're not only going to look at the immediate problem and treat that, but you're going to treat the person. If they come to you and they want your help, you'll observe and make recommendations for posture, for fitness, and for nutrition, and then the metabolic side. The metabolic side is extremely important. Now, most people are going to be balanced. You don't worry. But you have to pick up those people who have aberrant hormones or who are overly inflamed. Because when you have inflammation or let's say too much sugar, etc., you're not going to get the end result. And you will know when you start treating a person, every time you look, you observe, are they getting better or are they complaining about this and that? And then you know that you have to expand your approach to treat. Now, yesterday when I spoke, I spoke about one thing that I'm going to repeat it because this to me is extremely important. When you look at whatever body part you have, you think fibroperiosteal junction, the attachment of a tendon, ligament, and so forth to bone. You think of micro or macro tears within the joint capsule, the ligament or tendon. These are all possibilities. I'm going to show you how this works with the shoulder because we'll focus on the shoulder. And then you look at entrapment of unmyelinated nerve fibers, C fibers. These are sensory fibers that are sympathetic. They can manifest themselves as a trigger point or as a tense muscle bundle in that area that you're trying to treat. And if you're not aware of it, you will miss it. Before we get started, I want to show you these things I've come across. It's not immediately. I learned by trial and error over many years. I've been practicing prolotherapy since 1982. And when I started, I didn't know. I had been an orthopedic surgeon in the United States Navy for several years, and we treated fractures. We treated shoulder and knee injuries in young sailors and Marines. And we looked at the patient, we just looked at the knee, and we said to ourselves, is it surgical or not? And then we would say, if it's not, we sent them to physical therapy and so forth, and it trusted that they would get better. I look back on that period. I want you all to remember this. We did much surgery. We were stationed in the Philippines at Subic Naval Base. Today, with knowing orthopedic medicine, today, I would have done less than 50% of the surgeries that we did for the knee and the shoulder. Less than 50%. To me, looking back on it, I said, where was I? I didn't know. We had training that was specific for what we did at that time. Now, each one of you are in practice. Each one of you will see patients of varying degree. And I want you to know that as long as you practice, you will always be learning. Every patient you see can give you another lesson how to do something better. And you want to be able to do that. If you do that, you'll find with time, you will be very happy that you're able to contribute so much more to the patients who come to see you. Now, I want to get started on this, but when we go over this, I'm going to remind you of the fibroperiosteal junction, micro tears, macro tears, because I don't think any of you have really paid attention to it if no one told you. This is the key to the shoulder. I've been told by several people that the shoulder joint is very difficult to treat. It is hypermobile, and we treat it. If they get better, they don't get better. And I had the same feeling. Now, I think I know how to treat it effectively, and I want to share that with you, so it'll be better. Next. Now, the shoulder girdle. Certainly, when you look at the shoulder, you don't just look at the shoulder joint, you look at the entire shoulder. Sternoclavicular joint, or acromioclavicular joint, the glenohumeral joint, also called the shoulder or scapulohumeral joint, and we call it the acromiohumeral joint. That's the space between the acromion and the head of humerus. Now, the bones, clavicle, scapula, and humerus, and muscles supporting stability and movement. Next. This is just a picture to show you all the muscles that surround the shoulder and the bone. What do you see most significantly here? You see how large the head of the humerus is related to the glenoid fossa. This is critical, and this is what causes most of the problems in the next year. Now, muscles of the shoulder girdle. Each muscle has a distinct function and range of motion. The joint capsule and supporting muscles are responsible for shoulder stability. Resistance at passive end motion will often identify the site of pathology. I will demonstrate that to you, and you do this by feel. Now, rotator cuff, certainly subscapularis, supraspinatus, infraspinatus, but that's not all. A major muscle is the long head of the biceps, brachii, and a lesser, but also important, the long head of the triceps. But you have to be aware of it. You have to see it. Next. This is a picture of the shoulder. You see the deltoid anteriorly in the pectoralis major. On the other side, you see the pectoralis minor. It's a little hard to know how that relates, but there's a way of identifying it. But this will be, you have to do this clinically. Every time I've seen an anterior shoulder injury, automatically we look at the joint capsule, the immediate rotator cuff, which would be the supraspinatus and infraspinatus. Yes. Very importantly, if it's an anterior shoulder problem, you must look at the anterior head of the deltoid muscle. Or you have to look at the pectoralis major muscle. It can be the clavicular head, the sternal head, or the abdominal head. And you observe. You observe for swelling over the shoulder, and it's usually very subtle. But once your eyes begin to look at it, you will notice it. Next. Posterior shoulder muscles. The same thing with the posterior deltoid, the infraspinatus. These are major muscles that go into protective spasm when the shoulder joint has been injured. So if it becomes prolonged, those muscles become a problem unto themselves, and they limit range of motion. Next here. Can you hear me all right? I don't know what it is. Thank you. I need your help. Okay. Thank you. Here is a typical rotator cuff. And you look at the subscapularis, supraspinatus, and infraspinatus. But on the left, this long head of the biceps, as it passes through here, is a major cause of anterior shoulder pain. Not the tendon itself, but the transverse humeral ligament and the coracohumeral ligament. When you look at it, you'll see more. But this is major. And this is the cause of a large number of patients who come to you with anterior shoulder pain. Next. Shoulder motions. Flexion, extension, abduction, etc. Now, these are the ranges of motion. Flexion can go up to 180, but rarely, usually 150 to 180. It depends if you're male, female, young, or old. Extension, 35 to 50, and that is usually normal. Abduction, neutral to 90. However, abduction in men is much less than women. You're lucky to get 70, but I will show you. You feel the end motion, and that tells you if there's a problem with that muscle or group of muscles. Now, here is down below is elevation. This is pure humeral, not pure, but nearly pure glenohumeral motion. From here to here, scapulothoracic rotation. Then the last several degrees will be adduction. And you have to be aware of that when you look, because it'll tell you oftentimes what the problem is. Adduction, lateral rotation, medial rotation. We'll go through all of these next. When you're examining a person, you always do horizontal flexion, horizontal extension, horizontal adduction, abduction. You say, why? A lot of people don't do it. If you come up and bring your arm here, and they can do it actively or you do it passively. If this is limited as compared to this, it goes down and this only goes this way, you know that the deltoid muscle at the attachment to the acromion is at fault, usually with inflammation of the underlying subdeltoid muscle when you do this. When you go back like this, and you can feel it, you're now tensing the pectoralis major and deltoid over the head of the humerus, and it'll tell you if you have pain here. Then you do horizontal adduction and abduction, and you get a feel for it. And then that will often tell you what to look for. Now, next. Always think of muscles that support scapular stability. And the serratus anterior usually is not a problem. But if it is, and the motion doesn't seem right to you, you look at all of these muscles, trapezius, levator scapulae, rhomboidus major, minor, serratus pectoralis minor, and so forth, that could be contributing to scapular dysfunction. Next. Sternoclavicular joint. Always look when a patient comes to you who's been in an auto accident or something of that sort. I've seen in my practice over many years people who come to me after auto accident, usually some time ago. And the first thing you do is you just look at the patient. And you don't go, oh, let's look at your shoulders. No. You look at the total person, and you scan the sternoclavicular joint. In a number of cases, I've seen anterior subluxation of the sternoclavicular joint, and not one person recognized it. What? Because they didn't look. They were not aware. But you here will always be aware when you see a person with a shoulder issue, you look. You've always checked the sternoclavicular joint, the clavicle, and then the acromioclavicular joints. And that's easy to do. Now, common disorders are acute or chronic sprain. You'll identify that by tenderness or anterior subluxation. Wonderful treatment, prolotherapy. You may have to do it 2 or 3 times, but that will work. And what you want to do is improve posture, because when you bring the chest out, the clavicles are pulled a little bit laterally, and it causes those joints to become less stressed or more functional. Next. Clavicle, yes. The costoclavicular ligament can be a problem, especially if there's a major subluxation. Usually not. Then you look at the subclavius. That can be a factor, but you have to look for it. If it's tender, it's usually at the origin. Now, this just shows you the clavicles. Now, on this side, you have dislocations of the clavicle, grade 1, 2, and 3. Now, sometimes, if you see the patient, you may say this person needs a surgical intervention to tie down the clavicle. But in grade 1 and 2, let me tell you, you can treat them with prolotherapy in a large number of cases. Fractures of the lateral third of the clavicle. If it's, you tape the clavicle downward and use prolotherapy in the fracture site. You can do this, and this is simple. You can do this in office as you follow them. Should I have a pointer? Yeah, oh, good. Thank you. When there is a major fracture here, and it's in a female, and the fracture is like this, if possible, women, more than men, would like to have the clavicle in alignment, even if there's a scar, because it looks better. When we were in the military and we saw major fractures in the middle third of the clavicle, we just put them in a sling. Hey, you'll get better. If you have a big bump there, it's okay as long as it's stable. That was the attitude. But always keep that in mind. Next year. Acromioclavicular joint. The common disorders are acute or chronic sprain, subluxation with instability, or arthrosis with or without bone spur. Now, I've seen many of these patients, and unless there's a bone spur that needs to be removed, prolotherapy is a treatment of choice, both not only for the joint capsule and the ligaments about it, but also for the coracoclavicular ligaments, trapezoid and conoid. But that's all. Sometimes you need to have the coracohumeral ligament. I don't see that as being a problem in most of the patients that I've seen. But this is what you want to look at. And if you can stabilize that joint, so in all the movements the joint is stable, it will probably be pain less. Now, sometimes you have to just inject the joint a few times, again, dextrose, and that'll help make the joint painless. Next. This is just another picture showing you the extent of the AC joint here. Next. Now, the glenohumeral and acromioclavicular joints. Again, take a look here, how small the glenoid fossa is versus the humeral head here. Now, you can't see it, but right here, you'll see more in another picture. This is a key to understanding what happens to the shoulder and how to treat the shoulder effectively. Now, certainly this, you're going to find at the end of this talk is major here. And also the joint capsule here and the overlying muscles. Next. They're remarkable for freedom of motion while retaining the basic structure of a ball and socket joint. The flat, small area of the glenoid fossa contracts and amounts to only 2/5 of that of the humeral head with which it articulates. The capsule of the glenohumeral joint is composed of 2 systems, the one anterior and the other posterior, united superiorly by the coracohumeral ligament, which can be a major ligament in certain injuries. The coracohumeral ligament surrounds the tendon with the long head of the biceps becoming continuous with the transverse humeral ligament. This is a key area of the shoulder, and this most people don't understand, but this accounts for a huge number of chronic shoulder problems. The coracohumeral and transverse humeral are responsible for maintaining the long head of the biceps, breaking muscle into the bicipital groove as it continues to the supraglenoid tuberosity and superior joint capsule. Now, the central element of the shoulder complex is the scapula, adapted to articulate accurately with conveying the thoracic cage. Why is this important? You see people coming like this. If they're old and they've been this way their entire life, that's the way it's going to be. You see a young person like this, boy, posture becomes a major issue. Becomes a major issue. Well, here again, glenohumeral joint abduction to 90 degrees, thoracoscapular motion 50 to 140 degrees, and abduction about 140 to 180. The joint capsule is strong but mobile, particularly posteriorly and inferiorly. Next. But again, the glenohumeral joint. Now, where do you get injuries in this joint? The articular capsule, certainly. Glenoidal labrum, yes. Coracohumeral ligament, but I'll go over these with you and show you. All of these ligaments can be injured. You have to look for every one in your mind when you see. When you're looking at the shoulder, what can be causing your problem? Next. This is the problem. This is the humeral head, and this is the glenoid fossa. I want you to do something now. All of you stand. Stand up. I want you to look at me and I want you to do what I do. You put your left hand on your right anterior shoulder. Now you bring the forearm into the abdomen and put it right here. Now bring it out. And you're going to feel the anterior margin of the humeral head being restrained by the anterior joint capsule. Now, come back. Put your hand, if you can, behind. Here. And then when you bring it in this area, you're going to feel the posterior margin of the humeral head being restrained by the posterior joint capsule. Okay, thank you. I want you to all do that. Why? Why? In nearly every sporting injury in young people that I see, there are three issues, either posterior shoulder pain, anterior shoulder pain, and sometimes lateral pain. In anterior shoulder pain, the first thing you look at are micro, or you're thinking now, micro or macro tears in the anterior joint capsule, right here where the humeral head is nearly every time. And when you feel that, you place the needle there and you direct it slowly, and you're right next to the joint capsule to the glenoid rim. Now, that is a major cause of anterior shoulder pain. When it is the joint capsule here, you can be assured that the pectoralis major, as it passes over the humeral head, goes into protective spasm, and in many cases can become a source of pain here. When people throw balls like this and they complain of severe pain here, the first thing you look at is the area of the joint capsule where the humeral head is being restrained. Then you look at the overlying deltoid muscle, sometimes the infraspinatus. And you find out now you not only have a joint capsule or ligament problem anteriorly or posteriorly. We'll continue. This is why this is so important. Now, next one, next year. Now, this is an inferior glenohumeral. This is very strong, and this is very important because there's a fold. We'll show in another picture, I hope. And oftentimes, if you hold the arm like this, you get adhesions in the fold. And the arm cannot go, when you go up like this, the humeral head is supposed to drop down, and it can't. If you have to be aware of that. Next. Here's the fold. You always have to be aware of this. Again, you see this rather large humeral head, and you see the space in here. Next. I'm going to go over this briefly. We've talked about this before, but I just want you to think again. We'll just go over fibroperiosteal junction injury, micro or microscopic failure begins to occur after it's having a greater, but let's see, I'm trying to look at it. Macroscopic failure begins. These are micro or macro tears here. Always have that in mind, because when you see patients, you're going to look at the fibroperiosteal junction, which Lenny talked about. Then you're going to be looking at tears within the joint capsule, anteriorly or posteriorly, and this is going to direct your treatment. And nerve injury certainly, but this occurs oftentimes in the supporting muscles. Next. Now, we've gone over this before, the periosteum, the superficial, and the deep layers. Next. Now, again, contributing factors. I'll briefly go over this because this is really important. One is hypermobility syndrome, Ehlers-Danlos, very severe. Aging, certainly. Nutrition and digestion with protein deficiency. That can be major. So you want to talk to your patients to see, and you get an idea if they have good nutrition, etc. Hormonal imbalance, uncontrolled diabetes, hypothyroidism, adrenal exhaustion. All of these can be factors in preventing the patient from getting well. Next. Now, this is what you see in young people, boys or girls in their late teens or 20s. Anterior shoulder dislocations. Common. In the Navy, when we saw that, we would operate on them. At that time, we'd take the tip of the coracoid process and we'd reimplant it into the anterior part of the glenoid, thinking that we had done a good job. Today, no way. Why? When you feel still and if you see this, the first thing you do is prolotherapy. And you start out, when you do prolotherapy, you start out at the mid portion of the joint capsule. And you hit the bone, you slide tangentially to it till you get to the glenoid rim. What are you doing? You know if the patient has suffered a joint dislocation, you know there are tears in the annulus. You know it. You can only identify it by pain patterns and by if you move out, oh, please don't do this. I'll give you an example of a patient that I saw a few years ago. 17-year-old boy. He wanted to be a wrestler. But his mother brought him here because both shoulders subluxed anteriorly every time he tried to be a wrestler. I looked, I said, oh my God, I don't know what to do about this. This was starting in March. He was going to college in October, in September, October. So every month we treated the anterior shoulder capsules and the posterior too. But the anterior was a major issue here. And then he went to college. I didn't hear from him. I saw the mother came to me later for another problem. Said, oh, my son is on the wrestling team. What? Yes, he has no shoulder problems at all. Now, there are two issues with this. One, obviously he had a weakness there. Why? I do not know. But his general health was very good. He was a fit fellow, strong, and working out in the gymnasium. I said, isn't this interesting? Now, anterior shoulder subluxations. You see that in men and women, anteriorly. Again, treatment of choice, prolotherapy. And you might have to do several treatments, but it varies with people. Posterior shoulder subluxations are usually voluntary to people who are very hypermobile, and if it doesn't bother them, you tell them not to do it. Posterior shoulder dislocation is extremely rare. I've never seen one in my career. Next. Now, there are 8 conditions that cause most shoulder pain. 8 conditions? Be more or less, but this is what I see. Now, sprain of the transverse humeral ligament and often the coracohumeral ligament controlling movement of the tendon of the long head of the biceps. Injury occurs at the fibroperiosteal junctions at the margins of the bicipital groove. Strain of the anterior head of the deltoid muscle and sometimes the lateral head of the deltoid muscle are attached with the subscapularis. I don't want any one of you to forget this. This is the most common cause of upper shoulder area pain. Injury to this, and I'll show you in other pictures how this comes about. If you remember that, you'd use a very small needle. That's why I use prolotherapy. And you have to identify by palpation. If you have ultrasound, you probably can do it. But you inject the attachment sites of the transverse humeral ligament primarily. And you move upward onto the head of the humerus and to get the coracohumeral ligament. And you look for areas of tenderness because there will be micro and macro tears in that area. I will promise you this is the #1 cause of upper anterior shoulder pain. Along with that, you're going to find that the anterior head of the deltoid, sometimes the lateral head, will be swollen. And if you stretch the arm out like this, put stress on those muscles, you'll feel tender muscle bundles throughout. When you treat that problem, the transverse humeral ligament, coracohumeral ligament, you take a 30-gauge needle, ½ inch or 1 inch, with just local anesthetic. You could add a little bit of dextrose, and you inject. If you use a ½ inch, you just inject subcutaneously. Remember what Lenny said: skin, muscle, joint. Sometimes you only have to do the skin. Sometimes if you see muscle bundles, you place a needle into the bundle, and you move. You then test the patient afterward. And I've had a patient that came to me after 2 years of frozen shoulder syndrome. I thought I would have to manipulate the shoulder. Not the case. I started with prolotherapy. I did 1 treatment and said, this is not your problem. All I used was 5% dextrose, 0.5% lidocaine, with a half inch needle and a 1 inch needle. And I went from the anterior lateral to posterior. It took several months and maybe 4 treatments. You saw him every 2 to 3 months. At the end of that, remember, he had 4 years of having a frozen shoulder. He had full range of motion. It's not simple. When you come there, you inject, and this fellow told me, oh, you missed this, you missed that, etc. So you'll go back until you get everything. Now, by combining prolotherapy and this, you will have a lot of control. Next, pain. Oh, there it is. I'm trying. Oh, it's here. Pain in the middle and lower portions of the shoulder joint cap. It's what I told you. The tear is primarily, or the injury is primarily anteriorly, and you can feel exactly where it is. And these are micro tears within the capsule that can extend all the way down to the glenoid rim. If you identify that, you put the pain, you put it under stress, so you know where you are, and you take the needle, hit the bone, or if you will, or the head of the, and you go tangentially downward. Nearly universally, you're going to find that the pectoralis major muscle overlying the humeral head is contracted and tender. You'll feel muscle bundles. Then you use neural therapy, and you'll find after a few treatments, the patient should get markedly better. Next. Posterior shoulder joint is the same. You see this in people who are golfers, who throw balls like this. I'll show you. Young man. He's 6'5", and a football player. He was going to Cornell as a quarterback. He did this for a year. He had severe posterior shoulder pain. His father graduated from USC, so he went to the orthopedic department at USC. 3 orthopedic surgeons assessed him. 3. They used local anesthetic in various sites, and at the end of that, they did not know where his pain was coming from. Did not know. What? I saw him briefly before he went back to school. There were micro tears in the posterior joint capsule right at the level of the humeral head margin. And they say, well, isn't this interesting? Because what I'm telling you now, most people do not know. They do not understand. But if you remember this, you'll find in your practices that you'll do very well. You'll find very, very much so. Now, I'm trying. Maybe I wear out the pattern. Lateral shoulder joint pain. Here, lateral. That's rotator cuff. Can be supraspinatus at the superior facet, the infraspinatus at the middle, and the teres minor at the posterior facet. It can be 1 or 3. Now, when you see that, the injury commonly. Oh, good. Remember this. The injury to the supraspinatus and infraspinatus muscles are usually the lateral margin of the facet joints that they become attached to. And even if you have minor tears, but has been separated dramatically, you can treat that and make that stronger with prolotherapy. Use a very small needle so you can be more accurate by the way you're treating. Now, when you see pain here laterally, just don't say it's rotator cuff and focus. Don't. You think lateral deltoid. Then you go and you take the needle along the margin of the acromion at the attachment. If you place a needle underneath the rim of the acromion, what are you going to feel? You're going to feel this subdeltoid bursa. And if that is thickened, then you treat that as well. You can do it with prolotherapy, or you can just do local anesthetic with a dash of corticosteroid. Now, when you see it laterally, and you're talking about the lateral head of the deltoid or the deltoid tuberosity, you have to remember when the muscle comes over the greater tuberosity, it's tethered by fascia, especially anteriorly here. And that too can be a source of pain. Now, there are other conditions that you have to look at. But if you examine the patient carefully, Rayanne is going to come up, and I'm going to show you how I do it. I'm not telling you you should do it, but we all have a way of identifying the problems. But first, you must identify the problem. Shoulder, sternoclavicular joint, acromioclavicular joint, and occasionally clavicle. Anterior shoulder, upper, lower, posterior shoulder, and that includes the glenoid too. And then you have lateral shoulder here. Now there are other injuries, but these are the common injuries. And if you know that, and you know what you're looking for, you can treat everybody very successfully. Very successful. With that comes exercise and graduated exercise. Remember, motion but you don't do big, you don't go, going back with heavy weights. You just do motion alone, at least in the first week or so, or for a few weeks, because motion is going to help you with that healing. Next. Inferior shoulder, strain of the long head of the triceps brachii muscle. You don't see that often. But when you are examining and you get a sense that there's a problem at that level, and because when you're doing this and you have limitation, you know that the head of the humerus is not dropping down to allow full motion. You know that. Sometimes you have to put a needle with just local anesthetic, maybe 5% dextrose, into that recess. And you may have to do it and then stretch because you know the inferior glenohumeral ligament has contracted. You know that. Now, cervicothoracic spinal pain. When the patient complains of pain in the suprascapular area, there's a multitude of causes for that pain. Number one are the facet joints from cervical 5 to about cervical 3-4. You palpate. If that be the case, then I would do just prolotherapy. If the muscle is in the suprascapular area, which is basically the trapezius, and to a lesser degree, more anteriorly, the levator scapulae, neural therapy. You observe. Sometimes, if it's more lateral, you have to pick up the scalene muscles where they attach to the transverse processes of the lower cervical femur. You see, when you do this, and you see a patient, you want to test yourself. I test myself all the time. What structures are in the area that I am concerned about? Do that every time in your mind. It's just in your mind. And that'll keep you very, very alert. Now, we talked about the cervical thoracic spinal pain here, the acromioclavicular joint, and the acromioclavicular, and myofascial pain. This is the deltoid muscle, pectoralis major, infraspinatus, and supraspinatus. I've seen patients that have come in that have had long-term pain. And we had one recently, a man who said, I can't lift my arm up like this. This is for 3 years. 3 years. You look, you didn't get an idea that the joint was. It was the muscles. Neural therapy. Local anesthetic in the muscles. When he left, we had full range. Obviously, you have to repeat it. You have to get him on an exercise program to maintain it. But this can be done. Here. This I want you all to pay attention to. Right here. The transverse humeral ligament. It's attached to the lateral bicipital groove in the medial here. This, when this is inflamed, when that is inflamed, it transfers to the tendon, then you get muscular pain all over the front. This is huge. And I don't think any of you have ever heard that. But now, none of you are allowed to forget it. This is going to be one of the best things that you can assess when you're looking at a patient. Now, here you have the coracohumeral ligament, which is a little bit more superior. Then, of course, you have the glenohumeral ligaments here, where you get the multitude of micro tears that go down to the glenoid rim. Very important. Next. Posteriorly, you have the same thing here, tears going down to the glenoid rim. Here, you would say, you see all these muscles, but you identified by your hand. Palpation is going to tell you exactly where to go. Next. Now, look at this. This is a major and look where he's taped. Why is he taped there? Strain of the long head of the biceps brachii muscle as it passes through as it passes underneath the transverse humeral ligament in the bicipital groove here. I've seen many athletes, they have the same problem. Because look, when you bring your arm up and you're stretching the long head of the biceps, and you do that enough, and these are healthy people, they come in with pain. You look at baseball players here, and then posteriorly, they can be here. It depends upon what sports they do. Next. No, my patient, he's 51. He is as fit as could be. He is so strong, being 5'10", and 178 pounds. He competes regularly in Masters tournaments. And for some reason, he loves this. But he comes to me after each major contest because everything has been injured. Now, I want you to look. Right shoulder, complete tear of the rotator cuff with retraction, complete tear of the long head of the biceps brachii muscle, left shoulder, partial tear of the long head of the biceps brachii. Still a champion. I say, look, what? He can take a man in his context and throw him over his shoulder. He can compete at the highest level. And look at the rewards he's got. So, I'm showing this to you. So you understand that if you have a rotator cuff tear and it's retracted, you can compensate if the patient is willing to put in the time to strengthen the deltoid, the pectoral muscles. It can be done. And sometimes you see patients that come to you many months after with complete retraction and they want help. I said, well, you reduce any residual pain and get them on an exercise program. And I look at, he's 51. I don't know when he's going to quit, but he keeps on going. Next. Now, examination of the shoulder group. I want to go over this just briefly, then I'm going to ask Ryan at one point here to show you what I do. You just observe. The patient is sitting in front of you. If they have shoulder pain, you'll ask them to take their shirt off, so you can look at the shoulder. All you do is look. You don't rush up and try to touch it. Once you become familiar, you'll identify any swelling within the deltoid muscle anteriorly, laterally. You go behind and you look for very subtle signs of posterior deltoid swelling. That's the first thing you look for. You certainly look at the sternoclavicular joint and the acromioclavicular joint. You test the joints by palpation and to see if they're stable or painful. You look for suprascapular muscle tension and scapular elevation. Interscapular myofascial tension, usually over ribs 2 to 5. Forward head and neck posture, that can be a real problem. Accentuated upper thoracic spinal curve, a problem. Swelling, anterior subluxation of the sternoclavicular joint, muscle tension, swelling of the anterior deltoid, and so forth. You haven't even touched the patient, but you're looking. And the patient is telling you where I hurt. Now, active shoulder resisted out trapezius and levator scapular muscles, C3-4, and spinal accessory nerve. Active adduction. Passive adduction, you do this. And you do it passively and see if there's any pain provoked in the upper thoracic spinal area. Next. Again, sternoclavicular joint. All you have to do is observe. See if there's swelling or anterior subluxation. Remember, I've seen a multitude of patients who've had this problem and seen doctors, no one ever looked. You will now look at this on a regular basis. The clavicle is usually not a problem because they're acromial alignment, tendon stability, subluxation, evidence of low separation with bony rack, inferior bone spur. That's an X-ray. Now, anterior shoulder. superior facet or greater tuberosity of the superior. This is what you're looking for. Oh, I won't read everything. It's too much. Lateral shoulder posterior. This is what you're looking for. You palpate slowly. You look. Next. Now, I like to look at active motions. I ask, how far can you bring your arm up? It means only to here. Okay. You do it in the scapular plane. You do it in the sagittal plane. You get an idea. You'll compare it, if necessary, you'll compare it with the opposite side and use one side as a guide. You go here to see about the anterior aspect of the shoulder. You see, you just do these things. An active extension, and passively you can do it later. But these give you an idea of what the problem is. Next. Now, I'm just trying to see here. Rayanne, can you come up here? What I want to show you. When you might want to test for strength first. It depends on how you do. Now, I'll ask her to push out here. Strong, you test both sides. What are you testing? The supraspinatus primarily. C5, and then you bring it up here. Deltoid muscle primarily, again C5. Then you push down. You're doing the pectoralis major, the latissimus dorsi, the teres major primarily, and also the pectoralis minor. Bring it down. Already in your mind, you're saying, this is C6, 7, 8. Already you've had a good view of what's wrong. Now, you come up here, palm down. Strong, you'd expect to be strong, but then you're looking at the scapula to see if there's any winging. That's the long thoracic nerve from C5, 6, 7. You already know that the muscle, that the nerve's in front. Now, if they complain of pain here, you've looked, you see swelling here. First thing you do, you bring palm down like this. Oh, you don't push here, you push here. Strong. Supraspinatus tendon. Now palm up. Up. Strong. And if this is strong, you test it here. What are we testing? The long head of the biceps brachii muscle. If that gives way here, you know you have a problem up here. You know that. Now, turn face that way. Then I come back. When you do this, you feel. You don't jump up, you feel. I know she's right-handed, and you're going to feel more tension. But if the tension is great and she says that hurts, you know you have an anterior capsular problem. You know that. Now, so we've done a long hand. Then always this, 90 degrees. But if it's this way here, and she says I have, and you pull a little bit, there's pain, you know you have a problem here. And you're going to turn that way again. Turn that. Then if you don't, you know you're going to have a problem here. That's a joint capsule with the overlying pectoralis major and deltoid muscles. You see how you're bringing in everything into exactly what's wrong. Now, let's say we've done motor function. We've checked in passive motion. And every movement means something. You go here, you don't just bring it out, you feel. You put your hand over the shoulder, you feel. Then when you come up and you're looking like this, I like to do it passively. I put my hand here. Once you learn, once you have a feel, you're going to know exactly where the problem is. Upper shoulder, anterior, inferior. You're going to know. Now she's normal, so nothing here. Look at it. But you see, the passive movements are extremely important. And you just don't say it's limited. You say in your mind, where is it limited? Superior, posterior, anterior. And this allows you to figure out everything. Thank you, darling. Thank you. Now let's see. Where are we? Next, passive shoulder motions. Next, assisted treatment considerations. 1, improve posture. Exercise to toleration to improve muscular function and stability. Nutrition to support healing. Local anesthetic, and sometimes corticosteroids to reduce inflammation. If it's severely inflamed, and you have the ability to see the patient in a day or two, you can use corticosteroid and don't feel fearful of it. But when they come back, you will use prolotherapy to get started with treatment. Prolotherapy for connective tissues at the fibroperiosteal junction and joint capsule tears. Neurotherapy for trigger points in areas of myofascial strain. Muscle shortening causing entrapment of unmyelinated C-part. Not uncommon. If you don't recognize, if you're not aware of it, you're going to miss it. Possible shoulder joint injection to reduce synovial inflammation with dextrose, local anesthetic, and maybe corticosteroid, but mostly dextrose and local anesthetic, followed by ozone. Shoulder mobilization if motion remains limited due to scar tissue. When there are adhesions that do not respond to your standard treatment with physical therapy, you can mobilize the shoulder in your office. You have to give the patient a degree of sedation. We would give them Demerol to start. We would inject the joint itself and the capsule around it, and then we would bring the arm up and over. And any adhesions that are resistant are usually right here, and you can break them. If you can, you then have to get them on a rehab program immediately, because if they bring it in, the adhesions are going to recur. Next. Okay, here's one of my patients. She's an interesting lady. She's from Columbia, nurse practitioner, and she does prolotherapy for various physicians. Now, I'm just looking at her here. I said, just take a look and try to see if you can feel anything else that's here. Sternoclavicular joint, palpating it, acromioclavicular joints. Next. I always want to check cervical motion. You've got to do that. And your extension, flexion, rotations, and side flexions here. And see if that provokes any pain or in the neck or in the shoulder area. Next. Arm is up. Here we're testing anterior shoulder. Here again, external rotation. Next. Next. This, don't forget this test. Don't forget it. And when you see it once being positive, you'll never forget it. And then commonly, what I see commonly is both injury to the anterior joint. It can be the transverse humeral ligament. It can be the body of the joint capsule. Oftentimes, you'll have another injury at the upper part of the joint capsule here. And you've got to look at both of them. And this is what she had. Next. Yeah, and this is going through the here. Don't forget this one. Don't forget this one. Once if that goes down, strong here but weak here, and that's pain reaction, you know that the transverse humeral ligament is at fault. You know it. You don't have to even ask. Next. Thank you. Now, I wish to stop. You have any questions about what I showed you? Yes, dear.
Thank you, doctor. I think it's very complete. and explain many things. I just want to ask if the patient have anterior labrum tear. Actually, which part is the most important we have to give pearl therapy?
Anterior labral tears do
Yes.
occur. When you have an anterior labral tear, you have strain of the anterior shoulder joint itself. Yeah. When I've seen several, and we've treated them successfully with prolotherapy. I'm not saying that some people don't require surgery. I'm not saying that, but I would certainly do prolotherapy first. Again, what I do, I bring the needle down to where the margin of the humeral head is located, here. I know where to look for the labral tear. Then you bring the arm in here, and you let the needle slide right down to the glenoid rim. And you feel, and you want the needle to be in the capsule. And the best thing to do is treat that. Now, remember, I showed you yesterday, acetabular labral tears. You have to ask yourself, is that the primary cause of the problem? You don't know that. In the hip, you could say possibly. More likely, the overlying joint capsule and iliofemoral ligament. Here, labral tear, yes, but I bet you it's a joint capsule at the glenoid attachment of fibroperiosteal junction. That's what I would work on, first and foremost. You give it 3 or 4 treatments, maybe a few months, and if the pain goes away, you know that you're right on. Make sense? Okay. Any other questions? I think we're all right. Next, we'll do the knee. Oh, yeah. Okay, good.
Okay, I think you have listened to a very complete shoulder. This is a clinical anatomy together with the examination, critical neuromuscular examination.
Yeah.
Not only the musculoskeletal
Yeah,
examination,
we've done the shoulder.
we also combine the neurology
Really
into
well.
that. So that's the most
Yeah.
important thing.
Yeah,
And also
really
the you can see what Dr. Beyond was trying to examine the patient ever since when the patient take off the shirts, walk into the clinic, and then what he started this lecture was exactly the advice he gave us back to 2005. So he's consistently doing the same thing. And then that's what we learned and then also try to practice and use in our practice ever since then. So it's also very important when the patient came into our office, sit down, the posture, the behavior, and then what the patient stressed on, so important. And in fact, the patient's history can tell you a lot of things. And then when the patient take off the shirts and exposure, and then you do your neuromuscular examination, it's not only a neurology exam. You have to combine the critical thinking of that musculoskeletal exam together with neurology. So I think that's the deal. And also, don't only treat the images. We have seen so many doctors around the world, so many patients being treated by the doctors only look at the MRI, only look at the ultrasound, then you start the treatment. No, that's not the practice. The practice should be just like what he showed us. Touch the patient, examine the patient, ask the patient to move, and you feel. So remember, he stressed again and again. You try to feel that deltoid. You try to feel that anterior joint capsule. You try to feel that posterior joint capsule. And then you get the feeling of that. So it's, in fact, many skills, even the ultrasound, dynamic ultrasound skills we were teaching here and back to HKIMM or back to any other workshops or even the workshop next year, we're going to show that what we learned during the neuromuscular exam, you move that, then you ask the patient to move underneath the ultrasound, and you're going to see it, you're going to show the patient. So that's the edge of this. But before you know how to do this test, you have to learn all this. This is in fact, he's already taken you from the basic to the advanced. I can tell you, it took me several years to fully understand what he's going to show you just within this hour. But this is so important. So I couldn't believe when I listened to this lecture again, I still get something. Okay, if you want to know what I got during that last hour, I can share with you, but I don't want to take away your time. So please.
Oh, thank you. Are you ready for the next talk? Okay. Knee joint. The knee joint is a major problem for many people, and it's very difficult sometimes to rehabilitate people. But you have got to know what structures are actually at fault in the knee, unless you have an obvious fracture and so forth. But I see mostly knee patients who come in hobbling, they did something, and you have to find out what is wrong. When you look at that, if you don't know the person, you just look at the low back motions, have them lie down, test the hip, test the ankle and foot, and then look at the knee. You can't do that with everybody. But if you do that, then you might find things that mean a lot. Because knee pain, obviously, is knee pain, but it can be referred. And when you first see the patient, you ask the patient to put his or her hand on where they are, front, side, or back. You always do that. Then you get an idea. I've had more patients come to me and tell me my pain is in the front, lateral or medial. Okay, you examine. It's referred from the posterior knee. Commonly on the medial side, it's the oblique popliteal ligament as attachment to the tibial plateau, or the semimembranosus muscle, again attached to the tibial plateau and downward and laterally. Not the pes rhyme, the semimembranosus, a major cause of anteromedial knee pain. Laterally, you look at the biceps femoris attachment to the tibular head. There's a fascial component that goes through the tibial margin posteriorly, and that can be a major cause of anterolateral pain. You keep that in mind when you're looking, so you don't fool yourself. You do not fool yourself. After you had the patient walk, you have them lie down on a table. You just observe. You test any leg length discrepancies. First thing you look at. You don't find it. You look for any varus deformity. If you see a varus deformity, you know there's stress on the medial joint, on the medial meniscus. You know that. Rarely lateral, but you look for it. If it's a female and the femurs go this way and the legs go out, and then in the course of the exam, you have in your mind, is there a lateral patellar subluxation? I'll just digress a little bit. I've seen several women who have subluxed their patella laterally. They go out here. They see orthopedic surgeons. And if they complain enough, they're going to recommend corrective surgery that requires 6 months to a year to rehabilitate them. If you understand the anatomy, you treat the medial structures, and I have not had one person requiring surgery. This you can do. Always think of that. Now, the patient's lying on the table. You see no effusion. You're looking for subtle swelling of soft tissues, medially or laterally, which will give you an idea of what to look for. The first thing you do is you compare hyperextension on both sides. You will get a feel if hyperextension is normal, bilaterally, and usually there's a degree of hyperextension that you look for. If one is missing, sine qua non, there has been injury to the posterior joint capsule or the semimembranosus or semitendinosus muscles. Sine qua non. Then you flex the knee. You compare both knees. If your knee does not move easily to bring calf to thigh, you immediately look at the quadriceps muscles here. And you're going to find that the muscles have been contracting to prevent pain. If it's been long-term, it becomes a major issue. This is how you start. Now, let's go here. Next here. Largest and most complex joint in the human body, a modified hinge joint, 3 articulations, the medial and lateral condyles of the femur, and the corresponding menisci and condyles. Motions are flexion and extension with axial rotation during flexion. Flexion, extension, axial must be stable, whatever the position of the limb. The cruciate ligaments must be regarded as collateral ligaments of the medial and lateral joints. I want you to look at this. Must be stable. When does it become impaired? When there has been injury to some structure, and that structure is the fibroperiosteal junction of a ligament, tendon, or muscle. You have to identify that, because that's very important. Next. The ligaments of the knee. Obviously, the articular capsule, the infrapatellar tendon, uncommonly a source of pain, but does occur. It does occur here. Tibial collateral ligament, tibial collateral ligament, we agree. They can be torn. I've seen that in major injuries. Some people would take them to surgery and operate and put them together and put them in a cast. Sometimes that cannot be done. Then you look to see, you palpate the ligament, and you see if it's close together. You might put them in a brace or a small cast temporarily. You want to quell inflammation, and as soon as you feel that you can, you use prolotherapy along the extent of the lateral collateral ligament or the medial collateral ligament and any other structure that was injured at that time. It depends on where you are. It depends what is available to you. But I remember I was in Peru once and we were treating patients. And if somebody came in with an injury like that, there's no way you're going to take them and say, oh, you need to see a surgeon, because they're not going to be treated because they don't have money. But if you know how to treat, you know what to look for, and you can work with them for several months, you can help them dramatically, and the disability should be minimal. Anterior cruciate ligament, when that's torn, it is torn. But if it is, you have to strengthen the entire muscles above and below the knee to provide stability. The posterior cruciate ligament, that's interesting. Rarely do you see a tear. But you see injury at the fibroperiosteal junction to the origin and insertion of that ligament. You identify it posteriorly. And there's a way, and the way to test it is to have the patient lie prone. You flex the knee to 90 degrees and have the patient bring his heel to buttock. You putting pressure, if it's painful or gives way, sine qua non, posterior cruciate ligament. And you palpate the ligament. Then if you want, you inject with local anesthetic. If that pain goes away and strength recurs, then you go back in and you put dextrose proliferant. Posterior cruciate ligament. Rarely completely torn unless it's a major injury. Rarely. Anterior cruciate different, it can be torn, partially or completely. Years ago, I treated young men, 18, 19, 20, who were motocross riders, either bicycle or motorcycle. They all crashed sooner or later. Knee injuries, not uncommon. I remember one young boy, they did a major surgery, they corrected his instability, got on his motorcycle, and tore the ligament again. Then his coach said, no, we're just going to put you in a brace and let you go. Strengthen everything else, and you can get away with an anterior cruciate ligament tear. Many professional football players have anterior cruciate tears, and they play. They just put a brace on. Now, the coronary ligaments. What is a coronary ligament? It is an extension of the joint capsule. There's a part of it that goes like outward to become attached to the margin of the meniscus, medial or lateral. It's part of the joint capsule. That can be torn, certainly. And when you look at it, you think in terms of the meniscus, you think in terms of the attachment of the joint capsule to the tibial plateau. You're thinking of two things, not one thing. And you place the needle very carefully, both along where you think the medial coronary ligament is and along the tibial plateau where you think the capsule is being attached. These are things that you think about. And it's very helpful. Next. Muscles of the knee. Quadriceps femoris, tensor fasciae latae, and the iliotibial band here. Let's go for that. When you flex the knee, that is quite painful, you'll find that you cannot bring the calf to thigh. And there's resistance over the quad muscles here. The resistance can come from injury at the fibroperiosteal junction to the top of the patella, or it can be micro or macro tears within the quadriceps tendon. I've seen that. I remember a young man had bilateral patellar surgery, and he had severe pain. The pain was in the tendon. Treatment, neural therapy. But maybe I used 5% dextrose, local and I went with a needle. It hurt like hell. After 2 or 3 treatments, the pain was gone. So you remember that when you're moving, you're looking for resistance, and you feel that with your hand. Certainly the pes anserine tendon is a major issue, and when it is an issue, yes, it's a triangular area on the upper tibia. Commonly, the injury site is at the medial border of the tibia, because that's the primary attachment site, and that's the first site to be injured when the pes anserine tendon is injured. Always look for that. Now here I say tibialis anterior, extensor digitorum longus, peroneus longus. You say, what? What? it may not be a problem. But you don't automatically say it's not going to be a problem, because why? It attaches to the tibial, muscle attached to the tibial plateau laterally. What also attaches to the tibial plateau, that's the iliotibial band coming down at Gerdy's tubercle. So you have to look at all three muscles, because remember, as Lane was saying, you can have foot problems, etc. But you always look there. Always keep that in mind. Gastrocnemius and soleus, here. Plantaris. The plantaris arises from the lateral supracondylar line of the femur. The popliteal right below. These can be painful, but you don't identify that much. The gastrocnemius certainly, but I don't see that often. I don't see that as a major. Now, anterior stability. Think stability of the knee joint. Anterior rectus femoris, vastus intermedius, articularis janio. Medially, vastus medialis. And here there are four insertions. Medial border of the quadriceps tendon, anterior medial joint capsule, often injured. Medial border of the patella, then the infrapatellar tendon. But this is where most of the injuries occur, because that's the first attachment site before it goes to the medial border of patella. Laterally, the vastus lateralis are two insertions, lateral border patella and infrapatellar tendon. Now, each one here, there's a medial patellar retinaculum and a lateral patellar ret that comes down from the vastus lateralis and vastus medialis. It initially attaches to the borders of the patella, medially and laterally, before it continues downward to attach to the tibial plateaus. Commonly injured. You don't always recognize it, but if you take a small needle, I use a 27.5-inch needle, 27 gauge head with dextrose, and I walk very carefully along the margin of the patella, medially and or laterally, and sometimes superiorly with dextrose. That is one of the most common sites of injury about the patella. Most common sites. Anterior cruciate, if they tell you that they have pain in the center of the knee, you never fully know. But you can place a needle, if you know how, you can place it right on the origin of the femur and of the tibia. But that's not the big deal. Transverse ligament you don't really deal with. Infrapatellar tendon, like, yes, that can be a source of pain at the tibial tubercle. And you will identify that clearly. Again, we go tibialis anterior. Next. Now, this shows you right here the attachment sites of tibialis anterior. Here are this is a extensor digitorum longus, and here's a peroneus. Look where they attach, and here, this is a continuum. Next. Here. Why do people say that if you have anterior knee pain, it can often come from the hip? They just say that blindly. Oh, you say that's referred. It is referred. But you want to know why it is referred. And that's right here. The intertrochanteric line where all of these muscles become attached and they refer the pain downward. So always keep that in mind. Next. This again shows the infrapatellar tendon. Yes, it can be injured here. Patellar retinaculum coming down, yes. And pes anserine, yes. Here, yes. Here, yes. Now, these are mostly the anterior structures. Oftentimes, when you go to a class and you study, you're taught automatically, you treat 1, 2, 3, 4, 1, 2, 3, you see? But when you go back and you're alone and you're looking at the anatomy books, know what you are injecting. The tip of the needle is going to tell you exactly where you should be and if you need to repeat it. So when you are injecting, your mind is on the tip of the needle at all times. And that gives you the best idea of what structures are injured and how to treat them more effectively. Next. Anterior cruciate, you certainly can inject this area a little bit harder, but there's a way. You do not treat the posterior cruciate anteriorly. I wouldn't do it myself. You certainly can treat this area and this area here, the lateral collateral and the medial. The medial collateral ligament has fibers, oblique fibers, superficial and deep. If you know that, when you are treating the medial collateral ligament, you think of superficial, that goes down, you think of deep, and you think of the oblique that goes back to the oblique popliteal ligament. So when you do that, you think about the nature of the ligament and where it is attached. Posterior knee joint. Oblique popliteal ligament is really a posterior capsule. It's major. It goes from the femur to the tibia, more medially. And when that is injured, you get an idea that the posterior margin of the medial meniscus is actually injured. It may be. Before you think that, you think oblique popliteal ligament and its anterior attachment to the posterior margin of the meniscus. That's what you think. The arcuate popliteal ligament is more lateral. That goes down the tibia, and you palpate. Palpate. You oftentimes can feel it. Now, the biceps femoris muscle. That can be a major muscle that causes pain, both over the posterior lateral knee, the lateral calf, because it attaches via fascia to the lateral side of the lower leg. But when it does attach here, it covers the peroneus longus and brevis muscles, and that can carry pain right down to the foot. So when you're looking, you're always thinking. Now, this muscle, the semimembranosus, when I've gone to courses and listened, I rarely hear that mentioned. It's just a muscle in the back of the knee. It's not just a muscle in the back of the knee. It's a major muscle that supports the tibial plateau. It's a major muscle. And you want to be sure when you're treating a patient that you've identified it. They can be lying on their side or they can be lying prone. But you palpate, and if you see tenderness going from the joint line downward past the conda, you know. You don't have to ask. And if you do that, you're going to find out. You're going to provide a lot of stability posterior-medially that often is a real problem when people twist their knees. It's a major muscle. Major. I want you all to remember that. And if you remember it, you'll be very happy, because that'll solve a lot of problems for you. The plantaris muscle, I don't know. Popliteus, that's a little hard. You know it might be tender, but there are nerves and vessels above it. I don't pay attention. The biceps femoris. Now here, not commonly, but it does occur. The biceps femoris has two heads, long head, short head. Long head is from the ischial tuberosity. The short head is from the middle portion of the lateral lip of the linea aspera. Well, you say, okay. I want all of you to remember that. Doesn't mean it's going to be relevant at any time, but I have seen patients that have had pain up and down. And we thought, geez, we don't treat the knee, but so-so. We treated the attachment site to the lateral lip of the linea aspera. It can be done. the pain can be helped dramatically. Next. Again, this shows you the now here. The reason I show this, when you have a knee problem and you get a lot of pain up in this area, you always have to go back here. Remember from yesterday, the sacral tuberous ligament goes here. And this becomes attached to the biceps femoris, the semitendinosus superficially, and more deeply the semimembranosus. And this can be a major source of referred pain here. It's not common, but it does happen. And when it happens, you want to be aware of it. Next. Again, this shows you a little bit more of the popliteus muscle. Here you have the plantaris, the gastrocnemius, and so forth. Here you have the semimembranosus that comes down here. And you see this is major here. The oblique popliteal ligament here. This is a major ligament. Next. Posterior cruciate. I don't know if any of you people inject the posterior cruciate ligament. You should learn. You have to be very careful because you're looking at the blood vessels and nerves next to it. This can be injected here to here. There's a way of doing it safely. And once you get that, you have another tool in which to inject the knee joint successfully. Medial stability, medial collateral ligament parallel, the deep and superficial oblique portions. And I want you also to think about this, maybe even look it up, because when you're looking at medial problems, you have to look at both deep, superficial, and oblique. The medial coronary ligament, the vastus medialis, first insertion is the medial border of the quadriceps. You don't pay attention to that as much as you do the anterior medial knee joint capsule. Then insertion on the medial border of the patella, which can be a problem, and insertion on the infrapatellar tendon to the tibial tubercle. And then the medial retinaculum. Always think medial and lateral retinacula and attachments to the patella. You'll find out when the patient comes in, I have pain here, that it's usually the medial or lateral retinaculum. Pes anserine muscles, yes. But remember, it's a medial border of the tibia. That's the primary source. Next. Here, you pes anserine. You see the three muscles here, how they go down like that. And here's a medial patellar. Look, this goes all the way down to here. Next. Medial pain. When you look at the adductor magnus here, adductor magnus, it attaches at the tibial tubercle of the femur. Pain can be here, certainly. It can be anywhere along this area, all the way up to its origin, to the lateral border of the ischial tuberosity. You don't see that often, but you can treat that. And I would, except for here, I would treat this with neurotherapy. I don't want to get involved with deep muscles and trying to figure things out. Next. Lateral collateral ligament, yes. Lateral coronary ligament, yes. Vastus lateralis muscle. If there's a problem, it's insertion onto the infrapatellar tendon. Lateral patellar, I've seen this frequently. The arcuate popliteal ligament, yes, but you don't really identify that clearly. The tensor fasciolatum muscle in the iliotibial band. You can get pain here. The pain is coming from the hip here. The tensor fasciolatum, which goes down about 1/3 of the lateral thigh before it becomes tendinous and then becomes the iliotibial band. So you look at this. What I'm trying to tell you is that most things are simpler than this. But what I want you to know is I want you to have in mind all the possibilities that can contribute to the pain of the knee. If you have that at hand, you are going to be much more successful. Next here. Let's see it. Let's see where I am here. Biceps femoris tendon attaches to the fibular head. It also attaches to the posterior border of the tibial plateau, but it continues down and attaches over the perineal and lateral muscles. Next. Iliotibial band. If there's a problem with the band itself, it's between here and here. And there's inflammation between the band and the vastus lateralis muscle. Not uncommon. And then you have to look here at the Gerdy's tubercle, which could be a problem, but that's usually related to the lateral patellar retinaculum. Next. Now, this is interesting. Let me see where I am so I can speak intelligently. The coronary ligaments, here. Posterior cruciate ligament, that you can treat effectively. Anterior, not so much. Now look here. These are the attachment sites, and you can try this for the attachments of the menisci, but I don't bother too much with that. I try to get the margin of the meniscus because when you put a needle in too deeply, you have to be very careful how you do it. And I've learned I don't want to do anything that makes me nervous. Next. Again, just reminding you. They get better when you look at their nutrition and hormonal balance, and all this stuff better. So you always keep that in mind when things are not working. Next. Well, this is what we've talked about. Next. Now let's look at these are referred pain patterns. Anterior hip joint, certainly. And that's through the quadriceps femoris, lateral strain of the posterior hip joint, and deep lateral rotator muscles. That can give you referred pain. Strain of the IT band, L5 nerve root. L5 nerve. I've had people saying, geez, I got terrible pain here. And the history indicates that it's probably a knee injury. It's not a knee injury. It's an L5 nerve root referred pain pattern. Medial knee. Anytime a patient comes to you, they have back pain, but they come here like this. I have terrible pain with medial thigh. You put your hand on that area of pain. It feels hypersensitive to you. Hypersensitive. It's internal disc disruption or of the L5-S1 disc affecting the S1 and S2 nerve roots. I've seen this on multiple occasions. Let's see. I think that's fine. Treatment. When I look at the knee, and it's a major issue, I do prolotherapy. Sometimes you start out with 10 or 15% dextrose with local anesthetic. You do, and you want to find the response of the patient. At the same time, if there's limited motion, I will inject 5 or up to 10 cc's, but mostly 5 cc's of 20% dextrose into the joint, and if I have it available, ozone. And this is a good way of treating it. Then you do neurotherapy for any of the muscles that are obviously tender about the knee. Now, you're going to see patients with knee effusions. It can be small, it can be large. Usually, if it's a simple, if there's been injury to the medial meniscus posteriorly, at the level of the oblique popliteal ligament, the attachment site. There's probably some minor tears there that are causing recurrent. So you take out the fluid. If it's bright, clear yellow, you know that's the problem. You just inject dextrose into the joint. If you have ozone, you add ozone. Then if you find tenderness along the posterior medial joint line, you inject that area too. That's a very easy way of treating it. Now, you're going to have some. I've had several patients that have come to me with terrible swelling of the knee. And when I say terrible, you can aspirate 20, maybe 30 cc's of clear yellow fluid. And I say to myself, there must be a major tear. Patients I'm talking about said, I've already seen the orthopedic surgeon, and he's already done surgery, or he's looked at me with an MRI, but I still have the problem. I've gotten every one better or well. Not overnight. It might take 3 or 4 aspirations at 1 to 3 month intervals. You do that, you look for usually tenderness along the medial coronary ligament or the medial joint line. And you take it posteriorly to where the oblique popliteal ligament is situated. You do that. And I recall very recently a 64-year-old woman who's a horsewoman. She's had terrible knee problems. She straddles her horses every day. And I thought I'd never get her well. She no longer has knee pain or swelling. But it took about 4 treatments over several months. Ozone. If you have it, fine. If not, you can't worry about it. I have it. The fellow I work with, I think I may have mentioned to you, he was into jiu-jitsu and he was Olympian. But he has now 2 total knee replacements. I don't know what he did, but one knee became swollen. I aspirated 90 cc's of fluid from the knee. 90 cc, it was dark, and I said, God, this is infected. So I told him, we put him on an antibiotic immediately. And I said, you need to get a culture to find out what you have. He never did that. But after I aspirated the 90 cc, I put in 20 cc's of ozone. Several weeks later, he aspirated 60 cc's, put in more ozone. A few weeks later, I aspirated 20 cc's, put in more ozone. Ozone is bactericidal and virucidal. Today, he has no swelling of the knee and he's full range of motion. I'm not telling you that you should do this. I'm not telling you. But these are options that you have when you have, let's say, patients that don't want to see the orthopedic surgeon and do not want to undergo surgery because they probably would have taken to the operated room, operated on him, cleared everything out, and said, you may need a new total replacement or something. And he didn't want to. I said, this is interesting. Next. Yeah, I think we've done enough, don't we? Next. No, we'll go through this. Just go well prone. Well, these are all the things I do next, as we talked about so much of this. I hope I've given you an overview of the knee. Most knee problems can be solved. It requires accurate diagnosis first, and prolotherapy where necessary, removal of synovial fluid if you have an effusion, and then a graduated exercise program. This will take care of most. Now, if you have major tears in the menisci, that's a different story. And you'll know that by the examination. But if not, and an MRI is taken, and you might see a tear in the posterior portion of the medial meniscus, but you can usually treat that non-surgically. Thank you for this part. Do you have any questions? No questions? Okay, we'll do the next. Are you ready? Cervical spine here. I can use a little water, darling. What? Yeah. I'm going to have a water break just for a moment. Okay, no, I got it up here, Libby. Thank you. I hope that was okay. Do you have anything else? I'll take a little water and we'll go to the neck and so forth.
Yeah, it's break time.
No, I can go. Do you want to stay or go?
It's break time.
Oh, it's break time. It's break time. So have a break and come back for part 3. Okay. Thank you. I did?
Yeah. It's 3:30 now.
My God, it's break time.
Okay. Middle open. Stanley want to share some fascia experience. So we'll allow the audience to come back a little earlier. I think it's short. Okay. So let's come back about 3:45. Okay. Yeah. And then we'll talk first more topic about why we should learn fascia, why we should learn prolotherapy, and I think that will give us more inspiration for learning. Okay. Thank you. 大家。
好，外面有茶点，好，我们大家可以休息一下，然后45分再回到这边，然后等下我们会再继续上课。 奥标志，然后这个就是第一我这个字吧，就是说里面有这个应该不是，因为要也有这个后就是主要的就是你加进来，然后把你那个后然后另外是然后再把这个然后这个
喂，
我们这段要用中文讲，因为我们有准备那个2张大大的感谢卡，要给2位讲师在外面，所以大家记得找时间去填一下，然后到时候给他 surprise 这样子。对。
Okay, so we met Lenny at 2013 in the Heikki Hemo Foundation. So that first time I met Lenny, I think, wow, this is a master. So the light integrity speech is really genius. Okay. And also we met another teacher, that is our brother Stanley, in the same year, the same place. Yeah. So totally changed the practice and help us to develop Taiwan's Pro Therapy Association. Yeah. So so Stanley is going to share about his learning, also about the fascia topic, and also why we should learn more, why we should learn from Lenny, from Bjorn, and how to improve our treatment. So maybe Stanley will talk for a while. Stanley will talk for a while for the sharing. So maybe you can take a short break. yeah. You like Steven?
So I remember in 2013 when we were first in Heikki Hemo Foundation in Madison, Wisconsin, we first met Lenny. Were you there? No. Oh, okay, I see. And that's also when we first met Stanley too. And it was funny because we didn't know he is a speaker, and he heard us chatting with each other in Mandarin. And actually, it's him who came to us and asked us where we are from. So it's quite an encounter. And then I remember at that time when the speakers were talking about biotensegrity, I had no idea what that is. Yeah, I had no idea, and I didn't even know how this would affect my treatment plan and how it affect my way to see a patient. It was not until recent years actually do I understand the significance of applying biotensegrity. I think the key concept that you need to know about biotensegrity is that every joint, every ligament can have interaction with each other, just like what Lenny talked about. Why there's some people this ankle hurts and you treat this ankle and they keep coming and they will tell you that, oh, now my back hurts, now my hip hurts. And that's from a long time before. That's like 10 years ago I had this pain, but now it's coming again. And this vision may wonder why. And now you know it's actually a result of biotensegrity. And also and that's also why Pro Therapy emphasizes the importance of multiple shots, meaning you have to look at the biomechanics and look at person more comprehensively. So you know that there are so many tendons and ligaments around the joints, and they are major stabilizers. You have to look into all these stabilizers. So these are the significance and the reason of existence of biotensegrity. And I think I deeply respect, honor Dr. Stanley Lam, because he is not only our mentor, but also very dedicated in teaching everyone in the world to appreciate the importance of Pro Therapy and the fascia concept. Yeah, because even though he is really a master in ultrasound, he doesn't just tell people to look for the lesion and inject it, but also how to evaluate really comprehensively and treat everything comprehensively. Yeah, so that's I think what's so different about Dr. Stanley Lam.
One big family. Also, the new IAMM, we are all one big family. Within this family, in fact, we support, we love each other, and we also want to pass on the spirit of this family is to see our patient, to examine our patient, to treat our patient with love. So this is so important. And also, the reason why I like to bring this lecture out is I want to echo what Dr. Bjorn and also Dr. Lenny is going to teach you. And also, I want you to listen carefully. In fact, today, I still learned something from, in fact, this is in Chinese, 温故知新, and then it's learn the new things from listening to the old things. It's very important. And then it's this, and also Dr. Daniel has stressed very importantly why I still urge doctors want to learn prolotherapy, go back to learn the traditional landmark guided prolotherapy first. Because number one, you need a comprehensiveness, and also you need to treat the biotensegrity. If you're not treating the biotensegrity or the so-called fascia integrity, I'm going to introduce to you. Maybe you already know all this, but I still want to stress: if you want to treat your patient well, you need to treat the root cause. And many patients come to see us because of different pain, different discomfort, disabilities, but those are the consequences only. So, for example, when Dr. Beyond was talking about the knee joint capsule torn or the long-headed bicep is getting damaged, do you think the long-headed bicep is working on its own? And do you think the medial meniscus, which is the commonest medial knee pain source, do you think the medial meniscus only works by itself without the supporting structures from others? For example, the obliquus popliteal ligament, and for example, the semimembranosus, and also the popliteus. And remember, the semimembranosus attached with the fibers attached to the obliquus popliteal ligament. And the obliquus popliteal ligament dissection has shown that it's attached to the posterior root of the posterior horn of the medial meniscus. And also, through that, the attachment, the semimembranosus attached to the posterior tibial plateau, medial tibial plateau. And what next is the extension of the obliquus popliteal ligament. And in fact, right underneath it, I have a video. Okay, it's okay now, right? I'm going to show you that the popliteus tendon is also attached right below it. So it's the same kinetic chain. So if you can treat that well, and also what's attached beneath the obliquus popliteal ligament and the popliteus, the soleus. Very importantly, the kinetic chain is keep going on to your Achilles tendon, and the Achilles tendon is attached to your plantar fascia and the long and short plantar ligament, and all the way to your metatarsal base. So that's so-called the biotensegrity or the fascia integrity. So remember, diagnosis start from the good history taking, and then start from the first thing you interact with your patient, and then listen carefully to what the patient want to tell you, and also more importantly, ask the patient why you developed this problem at that time, what happened at that time. So no matter how trivial, how the patient interpret, this is irrelevant. You don't have to know my gynecological problem. I come to see you for low back pain, for hip impingement. My gynecological problem is nothing. So I'll give you an example. Very important. And also a patient with anterior knee pain. Why? You have to ask why. I always ask myself, even I found a patellar tendonitis, even I found medial meniscus tear, even I found a cartilage damage, or the femoral condyle was completely gone. That's only the consequence. You have to find out why the patient developed that. And then also a patient with a supraspinatus tear. Why it's torn? Why it's only the right side? And the patient is left-handed. But why the right side torn? And why? Why the infraspinatus is also attached, interwoven together with the supraspinatus? Why that part was not torn? That tells you something, and then you have to find out why. So remember, this is the biotensegrity is the strings are the ligaments, the tendons, the joint capsule, the muscles, and the nerves, the blood vessels, all the soft tissues. They give a compression force towards the bones, which is the rods, within that biotensegrity system. And then I can see a model right there. And then if you want to just try to feel it, go and feel it. Our body is the same. The strain and the counter strain should be balanced against each other. If there's something wrong with the rod, for example, you have a stress fracture, and you have a cartilage damage, that will give you all the forces were just transmitted, compensated to other parts of the body. It depends on how you compensate itself. Each of us will compensate differently. That's why each of us is unique. Each of us will develop different soft tissue injuries from the injury to the bone. Also, if you have any strain to the tendons or the muscles, or any sprained ligaments or the joint capsules, the forces will just distribute among the whole body. Other parts of the body will just share the forces and then present with pain. And then the pain bring the patient to see you. It's not because the root cause bring the patient to see you. It's the pain bring the patient to see us. That's the problem. So each time when we're facing a patient or any one of you with whatever problem, during the break time, I talked to one of our doctors here. She has neck pain. So I'm going to, initially I take, she's the translator. So initially I took away some of the slides, but I add them back because I want to share with you the importance of something. So this is a knee. Many doctors only think about the joint capsule, the ligaments, and the tendons, and then most of the radiologists will only report this part. And left behind the muscles, the tendons, usually not reporting that much. Even you can, physically, you can feel that, your quadricep, the right side is much smaller and atrophy comparing to the right. The radiologist will not say that because the radiologist only look at one side. But you, as a clinician, facing the patient, you have to look at the patient as a whole. And then none of the reports I have seen in the world will report about the fascia. And remember the knee joint, very importantly, it's a junction between the fascia lata, the crural fascia, and the popliteal fascia. And the fascia lata, in fact, continues with the gluteal fascia. The gluteal fascia continues with the tensor fascia, with the lumbar fascia, and all the way to the trapezius fascia, infraspinatus fascia, deltoid fascia, and all the way up to even the prevertebral fascia of your neck. So everything is connected. So this is just a patient post ACL reconstruction. It's very stably repaired right knee, but the patient still felt the right knee is unstable. And then the patient felt each time when he's doing this sudden turning, and she felt, the knee is unstable, and she couldn't run, she couldn't jump, she couldn't sudden turn, she couldn't return to his sports. And then when I examined the knee joint, I felt the right knee, the reconstructed knee, in fact, is more stable than the left. Pivot shift negative, Lachman negative, anterior jaw negative. So in fact, it's very stable. The other knee positive for many tests, but she felt the other knee is completely normal. Okay, why is that so? Then I look at the the images. So I found this, this is the medial knee scar. The neovascularity is less. Remember, within 9 months post-surgical, the scar is still repairing. See, if you see neovascularization, vascularity, normal. After 9 months or after 1 year, you still see that. This is usually abnormal. I see the other view, normal. To me, it's quite normal. Then I look at this lateral scar. The lateral scar still has a lot of neovascularity. Still with the vascularization is still prominent to me, even to the skin, which to me is quite abnormal. Then I tried to see this scar, and then the lateral view is also the same. The transverse view is also the same. Then how to diagnose a scar which is abnormal? You have to see the. It's not working. Okay, I translate this scar, the skin underneath the subcute. I can translate the skin to lateral side much easier than translating to the medial side. So translation to the lateral is easy. Translating to the medial is significantly dragging. That's the reason why the patient developed this instability. Because when he's trying to do this, and then the patient felt, oh, skin dragging. The dragginess, this gave the patient that instability feeling. Then I moved the patient to the translate the skin proximally and distally. I found translating proximally is easier. Distally is difficult. This is slightly difficult to understand, I know. Then I asked the patient, I tried to use the normal leg in comparison with the abnormal leg. So I used try to feel that normal leg and then scan on the lateral skin and ask the patient to flex and extend. This is the finding of that patellar tendon with a lateral retinaculum. I can see, oh, the movement is in fact quite smooth without any gapping. That's normal. Then I go to the abnormal side. I asked the patient to do this flexion and extension again. Then I felt the lateral retinaculum and the lateral side of the patellar tendon in fact has a slight gapping when he's doing this flexion and extension. And the patient felt discomfort with my probe on that lateral scar. This immediately tells me the scar is having some trouble. It is the scar and the fascia which gave the patient's instability feeling, and the patient felt unstable, especially when he's trying to do this and couldn't run, couldn't jump, couldn't go back to the sports. And then just the glucose polotherapy to this, 15% glucose polotherapy to the scar, because this is a loose scar, and the patient back to his sport. One treatment only, once. Okay, this is another young athlete being contused over the posteromedial corner of the knee, exactly what Dr. Beyond was talking about, semi-membranosus. Contusion over here, causing what problems? It's not a big deal, right? But this kicked by his teammate to that posteromedial corner, and then developed this instability, cracking, crepitation in the front of the knee, patellofemoral pain syndrome, so-called, okay? And when I look at the ultrasound MRI, I can see a bone erosion over the lateral femoral condyle together with the bone marrow edema. So are you going to do an intraosseous injection to that lesion to treat the bone marrow lesion? I didn't. Are you going to do an intra-articular, intralesional injection to that femoral condyle defect? I didn't. Those are not my treatment goal at that time. I take a look at the site he was being kicked. Just look at that. Then I look at, this is the medial gastrocnemius. Can you see the epimysium, and then in conjunction with the semi-membranosus? This is the site he was kicked. I can see the thickened epimysium together with the fascia. Then I just try to use my finger to rub on that transversely. The patient felt, wow, that's exactly my feeling now when I run. It's apart from the front crepitation, he felt a lot of discomfort over the semi-membranosus. And then, in fact, what he told me, I felt my medial meniscus was torn. In fact, the MRI did not show the medial meniscus was torn. It's just the semi-membranosus is having some tendinosis. Then the patient felt my medial meniscus was torn. Then I look at this. Distally is normal. This proximally, you can see this gastrocnemius epimysium, which together with the fascia is having some trouble. Oh, you guys are seeing the dragging of the because of this. I think it's the speed of the internet. You're not seeing a very good video, but here I'm seeing a very smooth video. But at least you can see some thickening of that epimysium. So this is how I made the diagnosis. I just used some micropore, take the patient along the semi-membranosus, along the bicep femoris, along the popliteus, and the patient get up from the bed. The pain was gone. The crepitation in the front was gone. Then the patient, I know this doctor know my problem. Then this is because in the first visit I couldn't do the injection. Then I asked the patient to take like this. I didn't learn any taping method from anyone. Probably one of them is Dr. Lenny. He taught me how to tape the flat feet. Okay, and but my taping method is slightly different because I usually tape along the fascia. So this is how I do the taping along the popliteal fascia, and the patient felt much better. And then in fact, on the day of the injection, he felt much improved. This is how the reason why this fascia being kicked, apart from the biomechanical, the so-called fascia integration between the semi-membranosus and the obliquus popliteal ligament and the popliteus tendon attachment is all attached to the same fascial line. In fact, the saphenous nerve and the medial genicular nerve, supramedial genicular nerve, it all has branches, comes out between the fascia, between the tendons. That's why that part of the structure is so sensitive. This is how I did the injection. I did the injection to the epimysium of the medial gastro and also to the semi-membranosus. For the time's sake, I just keep going. In fact, I make the speed so fast to save time. Okay, so this is how I do the injection. And then you can see I'm injecting. This is in fact the site of the semi-membranosus attachment right here. And below it, just distal to this, in fact, is the popliteus tendon. So maybe I can share with you this group later on. I take a video of this to let you see the smoothness of the video, because here is lagging behind so much. So this part is where what I talk about. Here is the semi-membranosus, and below you're going to see a jump, a slope, and then below that is the popliteus tendon attachment. So they are attached to the same fascial plane. So this, probably all of you know this infant spinatus fascia, which was published last year. But the reason I still brought this out was to show you the importance of treating the popliteus, the infant spinatus fascia. This is, in fact, here, this video, in fact, shows you the importance Dr. Beyond showed you just in his lecture. Why we need to fully expose the patient and ask the patient to move. Very important, because you want to see the asymmetry of the muscle. In fact, I usually ask my nurse to take a video of the patient with the patient doing the movement. Then with the patient doing the movement, I want to slowly play the video together with the patient and then show the patient the skin creases of all those asymmetry of the muscles. I just keep going because I still have. And then you can use your dynamic ultrasound to prove the loss of the resilience of the fascia. In fact, it's right at this corner here. It's lost the resilience of this infant spinatus fascia. But I don't have time to go through all this. I just want to point out you can use dry needle into the fascia and then to see whether you can change patient's feeling. And you can also prove that with a dry needle between this deltoid fascia and infant spinatus fascia. In fact, you can get the trigger point of the posterior deltoid and the infant spinatus. You can get rid of those trigger points by just dry needling the fascia in the junction between the two. For the time's sake, I just keep going. And then for the injection part, in fact, I like to give the so-called prolotherapy or the fascia injection into the junction between the fascia. This is the junction between the trapezius fascia and the infant spinatus fascia. Very important part to inject. You can get the trapezius back to work, and you can get your infant spinatus fascia back to work, especially you're facing the patient, rotating the neck to one side, and then facing the clicking sound. This is super important. This is injecting at the 4th rib level. And then I'm going to show you, this is injection at the 5th rib or the 6th rib level. And this is injection at the 7th rib level. And because you can see the trapezius has left the medial end of the scapula. Very important structure. To meet the edge of that trapezius, you have to inject. Which a lady about 50 and then came back from Germany back to Hong Kong. He's
这
born
是一
in
个大概50岁的女
He
性，从德
married a man
国
in Germany
回到香
and
港。
he had
这是一个香港女性，不过她嫁给了一
excessive
位
menstruation
男性，到
and then with
在德国的男性。
uterine fibroid. And the doctors in Germany worried about cancer and then did also with anemia. That's also indicator for surgery. And the surgeon
她的有一些妇科的问
the
题，包含
gynecologist
在
did
子
the
宫内和
laparoscopic surgery, but also told the patient that we need to do an open surgery to take out the big tumor. And then it ends up with 4 ports with laparoscope, 1 cesarean scar. And the patient was on 2 drains for about 14 days. And the patient could walk, could sit, no problem, within those 14 days. But 14 days later, when the drain was removed, she felt significant tearing pain when the drain was taken out. And ever since then, the patient developed fullness in the abdominal wall. Even she felt she's like pregnant. A swelling of the scar, a swelling of the abdominal wall. And she developed low back pain, neck pain, and eventually anterior hip impingement. He came to see me because of anterior hip impingement bilaterally. So I keep going. This is for the injection of the infant spinatus. I think we don't have to stress too much about that. I have gone through that, and then I go to this. I came back to that case later. But this is, in fact, one specific, oh, it's gone. Why? I have to share again or it's, okay. Okay. This is reason I brought this out is when you try to scan the back or lower back, please do this panoramic view. In fact, what you can see here on the left side, which is the patient's right, this is between the fourth and fifth ribs, and it's in the pleura region. You can see, I can see the pleura bilaterally, symmetrically. That means I'm on the same level. But can you see the trapezius over here is like still attached to the scapula? But can you see it is already detached over the other side? So this asymmetry immediately told me that the trapezius over the patient's left side was not firing that well, was not right. So this is immediately gave me a diagnosis. I have to work on something here. Then I back to another level, which is the lower level, like a seventh rib. Now it's more symmetrical. So that's probably not the cause. This is and then in fact on the lower back, the same. You can see a lot of, so this is the patient with anterior impingement and then with labral cyst. You can see the, already with a labral cyst, and then with the psoas is also having some tendinosis. Then you ask the patient to do this flexion and extension. You can see the anterior impingement significantly, and that's also with the psoas tendinosis. Even you can find a bit of the cyst next to the psoas tendon. So this patient, when I asked the patient how you feel that when you try to get up from supine to sitting, she's trying to throw herself up. Means she's trying to do this and get up. Both feet, throw herself up. So it's each time, he's not using the abdominal muscle. She's using the psoas, the iliopsoas, trying to get herself up. So that's why she got this impingement. And then when I try to scan the linear L-bar, this is above the scar, above the umbilicus, which is quite normal. This is below the umbilicus. I can see this. This is a derangement in the linear L-bar. Linear L-bar usually is trapezoid shape, but this one is not a trapezoid. This one is like this. So when I do the scanning, you can see it's quite irregular with a little bit of fluid inside. Oh, you guys are not seeing it that well because the video is not smooth. But at least you can see how irregular this linear L-bar is. Then above it, above the umbilicus, very soon you're going to say, this is normal. This part of the linear L-bar is normal. Below the umbilicus, abnormal. I asked the patient to do an MRI. In fact, you can see a torn linear L-bar together with the abdominal fascia right below the umbilicus, which I'm going to share with you later on. So this is abnormal. That corresponds to the MRI findings. And also, when I do this, the test is very simple. I just hold on the linear L-bar and ask the patient to get up from supine. And then the patient could fire the abdominal muscle and then get up without the impingement of the anterior hip. So that's immediately made the diagnosis. And then the patient felt immediate relief of the low back. This is the first visit before she went home. I just do this taping. because I couldn't do any injection on the first visit. I do this taping, and the patient get up from the bed, no pain. Low back pain relieved, abdominal muscle firing, and then the hip impingement. When she went home, she gone home, no pain. And of course, we need to do some injections. This time, I use some PRP to get into to that scar together with some thrombin, and that's how we treat the patient. I think the video is not smooth, then I just forget it. I think this is the last case. After this last case, I will stop here. This is a retired clerk, and suddenly developed tightness and dragging feelings in bilateral lower limbs, the right more than left. And the dragging and the lack of flexibility, elasticity feeling even affected her swimming. So even inside the swimming pool, when she moved, she felt the dragging and the lack of smoothness and the heaviness. Okay. Each steps of walking or each movement of the legs is heavy. And she gradually developed bilateral upper limb problem as well. And she developed significant snapping of the bilateral pes anserine tendon here. In fact, each steps when she walked on my treadmill, we could just use our ear to hear the snapping. It's like each step is like this. So it's not funny at all. It's painful, in fact. And then the snapping, of course, when she went to see a lot of doctors, all the MRI shows so mildly degeneration, not significant. This is how I firstly treat the patient and made the diagnosis. This is, in fact, my first taping on the glute because the right side is worse than the left. After tape this, she felt bilateral knee is getting improved slightly. Then I tape the infraspinatus and also the latissimus dorsi, and she felt even better, much improved bilaterally, lower limb. She didn't mention too much about the upper limb. And then I tape the trapezius, and then the patient felt, oh, that's significant improvement in bilateral lower limb. And in fact, eventually, I also taped this popliteal fascia, but she felt this is more stable. But before you tape my popliteal fascia, she already felt a lot better. And eventually, this is the reason I want you to learn carefully about what Dr. Beyond and Dr. Lenny are going to talk to you. Very importantly, you have to learn the comprehensive prolotherapy before you can know how you can critically make the diagnosis of your patients. In fact, this patient is not difficult to treat at all. Even if she can find a good prolotherapist and do the traditional comprehensive prolotherapy, I still think without my so-called ultrasound-guided injection technique, she could recover. I believe so. And this is, in fact, when I try to one thing I want to point out very importantly is this muscle. This is the latissimus dorsi muscle. There is only one muscle in the body which has the neck innervation, which originates from the lower back, is concerning as the lower back muscle, but it controls your upper limb. It's attached to your humerus. And each movement, if your upper limb, reach out, throwing, shaking hands, whatever movement of your upper limb, in fact, this muscle is doing his job. Very importantly. So Don't neglect this muscle. And then also remember the muscle innervates by your neck. The thoracodorsal nerve is from the neck. So a neck nerve supply a lower back muscle, controls your upper limb. None of the other muscle in the body are doing this job. So this is so unique. And this muscle, the origin of that is thoracolumbar fascia. And the thoracolumbar fascia connects your trapezius, latissimus dorsi, infraspinatus, and your glute, and all the way to your lower limb. So thoracolumbar fascia, in fact, also contains the deep, the superficial, and that means the superficial is the posterior, the middle, anterior, and it continues with abdominal fascia in the front. So it is so important. And also try to remember, read your MRI yourself. I haven't seen a lot of the radiologists will report this so-called fatty infiltration of your multifidi muscle and the longissimus muscle. Read the MRI yourself. Normally, the muscle should look like this. This is a black color, normal. Abnormal muscle is white. Remember that. And also, I want you to listen carefully Dr. Lenny's lecture later on. Remember, your tongue is attached to your big toe. This is the one single fascial line which attached your tongue to your big toe. That's why I've seen patients, in fact, I have seen a lot of patients with TM joint problems. But you can treat, if you can fix the whole body's bowel tensegrity, even the lower limb. Many times when you see a patient with the clicking of the TM joint, how many of you have asked the patient to take off your shoes? Let me see your big toe. If you have that gut to ask your patient to take off your shoes and let me see your toes. And then, can you tell me when did you start to feel your foot pain? And then, if you have that gut feeling, number one, if you can see the patient with TM joint clicking sound, and then you just try to see the patient walk and find the faulty gait, problem in the gait, and then you point out the gait, change the gait, and ask the patient, can you feel your TM joint again? If you have that gut feeling, you are successfully graduated from this class. So I think I won't take a lot of your time. So thank you very much for your attention.
Thank you for Stanley. Yeah. Okay. So I think ProTherapy is gradually improvement because fascia is more and more researched. So it helps our practice more in the future.
Yeah, I still remember, the first day when I learned the high D and low E, and then also the first day when I still, that's back to 2005, and it's also the year HKIMM formed, and then also when I met Fred Daniel in 2013 in Wisconsin. So I still think all those are the very important cornerstones for all of us because it changed. 2002, it changed my life. 2005, it changed my life again. 2013, it changed a lot of doctors' life in Taiwan. So, but I still, as the first statement, this is a big, big family. And also, if you can sense Dr. Beyond and Dr. Lenny's spirit of teaching at the age of 1888, after 2 hours of lecturing, oh, this is the break. I didn't know that. You know what kind of spirit was that? This is a spirit of love because he loves all of you. He loved all of us. And then that's why he still, flew a long, long way from United States to this city and then to share with us. So let's give a big clap to Dr. Beyond. and also Dr. Lenny. So please learn with your heart and try to see your patient, take history with heart, and also try to treat your patient with heart. Very importantly, your patient can feel it, I believe. Just now, I still can feel the same love Dr. Bjorn and Dr. Lenny were giving us. So that's why I believe with this spirit, if you pass on, and also when you become a master, please pass on this spirit to the next generation doctors. So we need more doctors in this family, more family members, please. Thank you. In fact, I'm going to leave you earlier because I still have a lecture tomorrow in Taipei. I wish you all the best and God bless you. Thank you.
Thank you.
Thank you, Stan.
darling.
Okay. Yeah. So I think we always have more to learn. Yeah. I hope I can keep learning.
Stanley, that was a wonderful talk. I really appreciate you. Thank you. Thank you very much. You take care now. I'll see you soon.
Yeah.
Bye.
Okay. So we come back to the
Thank you.
Protherapy.
I take this? Yeah.
Now it's the turn of
It's
mid
neck,
back, neck.
neck and low back, neck and mid back. Yeah, good.
Bye-bye. Okay, so it's a very important part, and I learned my neck treatment skill in Cancun from Dr. Bjorn. So that changed my treatment so much. So I still use Bjorn's technique every day. Yeah, so hope everyone can get the same teaching from Bjorn again. Okay, thank you.
Thank you. Well, wasn't that a wonderful presentation by Stanley? I was very impressed. Stanley is a good man. My talk, examination of the neck, mid-back, and shoulder girdle. It'll be an overview. But before I start, I want to tell you what you commonly see or what is commonly seen in the neck. It's not as simple as you think as it should be. First, think headache. You think cervicogenic headache, because cervicogenia is a major factor in my practice that I see frequently, or instability at the base of the skull. Next, you think in terms of nerve pain or muscle pain, facet joint pain in the neck. Then you think of pain over the suprascapular areas, and then you begin to think of pain and numbness in the hand. All of these things will come to you in your career. It's not easy, but I'll go over that which I have learned and which I understand. Firstly, cervicogenic headache is a major factor. Oftentimes it's considered migraine or migraine-like headache. In recent years, I've had a number of patients coming to me with a headache, and it's basically suboccipital. It certainly can be due to migraine, etc. But those people that respond have injured the muscle attachments to the base of the skull, from the superior nuchal line to the inferior nuchal line. It can be the sternocleidomastoid, it can be the trapezius, the semispinalis, and so forth. There's about 11 muscles between the superior and inferior nuchal line. And it can cause headache, it can cause instability of the cervical spine. Recently, I saw a young man. He's hypermobile. He's 6'3", and he was a bodybuilder. He overdid, and all of a sudden he woke up one day and he couldn't hold his head up. Couldn't hold his head up. He had to quit work and he was at home. And he could only stay up for a few hours a day because his neck just didn't feel right. Radiographically, everything looked normal. But he came upon prolotherapy. And he lives in Orange County, so he got my name and he came to see me. This was a year ago. And he said, I can only be up for a couple of hours because my head doesn't feel right. Prolotherapy. We started treating the muscle attachments at the base of the skull from the mastoid process on either side. Now, I'm going to give you a warning. I'm going to tell you what not to do. Never use a long needle. Only use a 1.5 inch, 25 gauge needle at the base of the skull. That's all you want. Why? A few years ago, I was asked to be an expert witness. And a patient was trying to sort out a headache at the base of the skull with a long needle. Push the needle right into the foramen magnum and base of the brain stem. Just put that in the back of your mind. Between the occiput and C2, you're very careful. And if you're doing the muscles at the base of the skull, a 1.5 inch needle. If you think you need to treat over the C1 vertebra, I would suggest to you do neural therapy only. 1/2 inch needle and inject local anesthetic, maybe with a little bit of dextrose. Don't do any more. Why? Why? If you place a needle into the foramen magnum, or you get in, you hit the the spinal cord, you'll never forget that, and you'll shy away from doing any more cervical treatment. I promise you. I have not done it, but I've seen this happen to other doctors. They've come to me for follow-up and further treatment as needed. So when you treat the neck, always look, is it a big man? Is it a small lady? You palpate to see the size of the neck. Always do that. And use the shortest needle possible for the patient. Now, headache is a big issue for many. And the fellow who had the instability, I've treated him for 1 year. I see him every 4 weeks now. I had to see him every week, then every 2 weeks. That was the only thing that gave him stability. Now, he's stable and comes every 4 weeks, and I think he'll finally graduate. A whole year? I don't know why. I do not know why. But he's hypermobile. Every other body part is flexible. So you know that there's a problem with the fibroperiosteal attachments that were extremely weak, and they had to be treated. Commonly, you will see neck pain, and it's really facet joint. The facet joints, after auto accident or injury, if there's chronic neck pain, it's from the facet joint usually, and then secondarily with myofascial pain are the paracervical muscles or the scalene muscles. Those, you have to look, and you have to look at very carefully. That can be treated effectively with prolotherapy. Over my career, I started in 1982, a long time ago. I've treated many patients with cervical pain, and usually women after auto accident and whiplash injury. What we saw were the patients who did not get better after 3 months of physical therapy or chiropractic care. And we saw quite a few people. And we found that prolotherapy made the biggest difference. But other things, posture, putting your shoulders back, simple, but hard to do for people. Diet. Those people who did not respond, had very little protein in their diet. So everybody that we treated had to have more protein. As soon as you gave them protein, the ability to heal was much better. Next. Oh. You have to look at this. You know, neck injury, certainly. Look at all of this. Boxing, terrible. I want to show you this. And this can be head injury. It can be 1 or 2 injuries. What happens to this fellow? What happened to Muhammad Ali? What happened to him? Too many head hits. Or you can have a major head hit. What happens? You get inflammation, number 1. You get scar tissue formation, number 2. It may stop there if you stop your sport. If you continue, scar tissue contracts over your lifetime. It compromises capillary circulation. One of my patients is a signature expert. He looks at signatures and tells you if it's valid or not for sports figures. Before Muhammad Ali passed away, he was asked to go to a hotel in Arizona, and Muhammad Ali was brought there. And he really liked the people around him, and he signed his name, Muhammad Ali. All morning, he got many thousands of dollars for that because his signatures are very expensive. I wouldn't understand it, but they were expensive. And my friend would validate them so they were correct. He could not stand up. He did. Somebody had to be behind him, holding him. When they had lunch together, he tried to bring his cup up. It went like this. They say, well, he has Parkinsonism, trying to say it's a medical issue. It's not a medical issue. It's a mechanical issue. Too much head hits. So remember, for yourselves, always protect your head. And always, when you see this in people, and they get concussions, you do everything to reduce inflammation immediately. You do that by an anti-inflammatory diet, omega-3 fatty acids, and the like. I'm just putting this out to you, just for you to remember. Always think in these terms. Always. Now, next here. Now, neck pain can be acute, subacute, chronic, mild, moderate, or severe. Athletic injury, work injury, auto accident is the big one. Predisposing factors: posture, fitness and health, hypermobility syndrome. Posture, when so many people don't think about it, and even me, I have to pretend I have a rope around my sternum, and I say when I'm walking, pull it up so I'm better. Next. Now, these are acute neck injuries, and we'll go over them. I'll tell you what you have to look for. Obviously, you're not going to see this. I won't see it. Cervical fracture. But if you see a person in the emergency room and they're on a gurney and they tell you they have neck pain, you never have the patient sit up or stand up. If you're in an emergency room, you get a recumbent X-ray of the cervical spine. Then you gently lift the neck forward and you do another X-ray. I have seen a fracture not through bone but through the disc. You say, what? I look, I say, what? And you see, my God, this man's unstable. And therefore, when you see that once, you may never see it again. But when you see, if you're in an emergency room and you're working there and you see a person on a gurney, be sure you get a lateral X-ray and be sure things are normal. Neurological function, you do that by having them move their fingers and their toes. You do it simply. Concussion, you can't make a decision unless they have been unconscious. Traumatic brain injury, very common. But what are we talking about when we say brain injury? We're talking about a contusion to the tissues around the brain, swelling, scar tissue. It can be mild, it can be moderate or severe. And in many people, if it's only a single incident, there will not be any recurrence. Now, paraspinal muscles, without question, and I'm going to go over this with you. This is important. Facet joints are important. Spinal canal inflammation, important. This is all for you. All for you. Let me go over it again. Paraspinal muscles, facet joints, spinal canal inflammation. And then disc injury, that's different. Why? If you are in an emergency setting, or if you see a patient who comes to you a week or two after injury, and they can't move their neck like this, and you ask, what did they do for you in the emergency room? Oh, they took x-rays, they said I was okay, they gave me pain pills, sent me home. Then they come to you and they can't move their neck. Oh my God. If that persists, that patient is going to have a lot of problems down the line. All of you can treat that very directly and effectively. You use local anesthetic, xylocaine, Marcaine, and corticosteroid. You don't give a lot of steroid, but in a 10 cc syringe, the local anesthetic to 9 cc's and 1 cc, and you take a very small needle and you go into the muscles. Short needle, 2 inches, no, not 2 inches, 1.5 at most. And depending on the size, you cover the whole neck. And then you gently mobilize the neck, not forcefully, and you get them moving right away. I'll show you an example. What happened? A patient that I've now followed for 30 years. 30 years. And no one understood his problem. I saw him 3 years after his accident. He was driving a car. A man in the back seat grabbed his neck and tried to strangle him. Pull the neck up like this. Pull the neck up. Just wrenched his entire cervical spine. What happened? All the muscles cramped. It was the muscles and the facet joints were inflamed. They looked at him, gave him pain pills initially, and said, go to physical therapy and they'll help you. What happened? The muscle attachments at the base of the skull were severely wrenched, as well as the muscles all the way down the cervical spine and the facet joints. This way, these facet joints became very inflamed and the capsules became stiff. Mind you, he went and saw a number of physicians. They looked at the x-ray or the MRI scan, sent him to physical therapy. I saw him several years later because no one knew what to do for him. He couldn't move his neck at all, and it was double the normal size. Why I'm telling you this is you may never see a patient similar to that or like that. But if you do, you can treat that patient if you can treat the patient immediately. If that person was disinflamed by just using a 1.5 needle and gently mobilized, he never would have had a problem after the recovery. He's now been disabled for the rest of his life. We've gotten him better, but never well, because of so many injuries that occurred with the scarring of the facet joints and the dysfunction of the muscles. Now, facet joints. All you need to do is put a needle over the top of the capsule and inject, and that'll be absorbed by the joints. And you gently mobilize to get motion back. Now, spinal canal inflammation. This, I don't want any of you to forget. Why? I've seen several people who have had whiplash injury, all female. They are referred to me for prolotherapy. Fine. Examination, examination, examination. I said immediately, This is not primarily facet, it's not primarily muscle, it's spinal canal. It's inflammation about the spinal canal, about the dural sheath and the dentate ligaments. If you don't catch that and you treat with prolotherapy, you can say, why doesn't the patient get better? Because it's wrong diagnosis. And I'll tell you, the diagnosis is not hard and it is not simple. It depends upon your hands and what you feel when you palpate the neck. The most recent one was a couple of years ago, in major auto accident. And again, the lawyer referred her to me and said, you need prolotherapy. All I did was put my hands on her neck and had her move. Oh, no, this is not. This is spinal canal. I want to bring this up to you because I just want this to be in the back of your mind so you can think about all the possibilities that occur. Now, well, what we did is she had a caudal epidural and the pain went away immediately. Now, disc injury is not common. Not common. They present to you with severe headache, usually auto accident, and we did a series of 11 people. They're all female. Why? Because they don't have muscle mass. If they get a major collision, it goes back and forth. They referred to me for prolotherapy. I'm looking, and I said, every time I extended their neck, they had lightheadedness, or they had a marked increase of pain, or they felt nauseous. Lightheadedness, marked increase of pain, and occasionally nauseous. That's from the, and I looked at that, and I said, I didn't know, I really didn't, but we did CT, we did discography. As soon as a needle, well, you go in anterolaterally, and as soon as a needle is placed on the disc space, you knew, because the patient was sedated, but they knew they had a lot of pain. Then when the discogram was done, it was just 2 or 3 milliliters of contrast in the center of the disc. The cervical disc being much different than the lumbar disc. And that pain was severe. Treatment was to inject that disc with what we call a prolotherapy solution for the disc. We use glucosamine, chondroitin, dextrose, and a local anesthetic, and we only use a small amount. We had to repeat that a few times, but all the women, except for one, got rid of their headaches. I only bring this up to you, so when you see a patient that is not getting better, the tenderness in the neck is, once you see it, you'll never forget it. When they have discogenic pain and is getting severe headache, and you put your hands, you know right away you have a problem. Your hands are an extension of your brain. You learn this as you go. And every time you see a patient, you're just putting your hand over the patient to feel. You do that enough, you'll find out that you'll gain a lot of information just by feeling. And you'll say, this is wonderful. Next year. This is just to show you natural movements, and I ask every patient to extend, to flex, to rotate, and sideband. I do it actively, then I put my hands, I want to feel. Then active, and then resisted, not so much, but active and passive I do. Next. Now, just look at all the muscles that come here, all of them. Look at this. Huge number of muscles. These muscles can be severely strained at whiplash, and you treat the facet joints, so with prolotherapy, and if you do treat the muscles, you do neurotherapy. You don't have to use corticosteroid if it's chronic. And you place the needle, I use a 27 gauge or a 30 gauge needle. You know immediately when you put the needle into the muscle because it's going to be tender, and you'll see the response that they have. And you say, we've got to deal with that. And what are we dealing with? We're dealing with muscle bundles where the fascia has been wrenched and you get inflammation. And then if there are